Baker Ripley's done for our community up to this point. And they did a lot of great work in reaching out, having hundreds of meetings with our community members at the junior high and the high school and the elementary schools. They were actively involved in reaching to parents, reaching out to youth to get input on how they wanted the buildings to be built and where they should go and how functionally they're going to work. So I'll stop there. And if some folks have questions, I'll be glad to answer them.
Great. Thank you so much, Representative. We're definitely going to come back to several points that you made, but I want to bring Joe into the conversation because you've also been very deeply engaged in this body of work over a number of years, but you sit at a health foundation. And so I'd love to hear more about how your organization frames this work, thinks about this work, and some of the efforts you have underway.
Thank you. And thank you for being here today. A couple of things just about me. I started my career 30 years ago at what is now called Baker Ripley. It was called Neighborhood Centers at the time. And so I've watched this history evolve in terms of how organization that was had its roots actually in two things, the resettlement movement early on, as well as the daycare movement. And so my role there was really as the Senior Vice President of Programs that helped with some of the initial thinking and working with Angela Blanchard in this work. And I'll also say, in terms of the Episcopal Health Foundation, and I actually do have a slide deck to show you a little bit about this work and our approach to it. We are a health conversion philanthropy, but we're organized as a public charity and a supporting organization of the Episcopal Diocese that owned a hospital system at the time and sold it. We did not maintain a relationship with the hospital, so he only sold it once, and are living off the assets. But part of the work was to create this foundation that's focused specifically on health, and that's health writ large. I think something earlier that Shirley was saying about having faith-based organizations involved in this work, the advantage of that, at least it has been for us, is that it really gives us cover to do things that political will is sometimes lacking where we serve. And so this is just a little bit about our foundation. In terms of our mission, while we're not specifically a place-based funder, we do invest, however, in healthy places. And so some of what I'll talk to you about today is about our approach in doing that. We're $1.2 billion philanthropy, and out of that $47.5 million operating budget, $40 million of that goes into grant making around this kind of work. And so the reason why us as a philanthropy, what our view on the use of grant dollars is that it's to catalyze and innovate. It's not the sustainable solution. And so in looking at who and what is in the community to actually help fulfill our mission around creating communities of health, one of the things that we looked toward was actually the presence of a community clinic, because quite often the people who come to these clinics, that's really their first stop. And while they present with asthma, for example, the question becomes and should become is why do you have this in the first place, particularly if we're seeing or clinics are seeing a large amount of their patients coming to their clinics with serious chronic diseases over a period of time. And so our work with this initiative, which is called the Community-Centered Health Home, it's a concept that was pioneered by the Prevention Institute, which some of you are probably aware of. In Texas, we have funded this as a model. We are actually the largest one to support Community-Centered Health Home. It's $10 million supporting 12 clinics. There was also work that was done by the Louisiana Public Health Institute, which used some of their proceeds from the BP disaster at the time to help fund this. And so what we've been able to do is really, the intent is to work with clinics to understand population health more broadly. I think that they're sensitive to their patient census, but the goal is to look beyond the patient census and to look at the population and the communities in which those patients reside, to ask, I think, the big why questions. And so if you look to the left part of that slide, those are the things that we know that we either want to encourage, to support, healthy places in population health, or some of the things that actually, because of some of the conversations we were having earlier about policies, systemic racism, that and other factors that really prevent communities from being healthy. And so the work of this initiative is to really how clinics think about working in their communities with partners, and that's partners that go beyond simple referral mechanisms. So if you're somebody that has diabetes, for example, the referral to the health to the food pantry, for example, should be more than just a paper referral. It's really that closed loop system of information that really becomes important in addressing what's happening in that community and developing a healthy place. So if we can move to the next slide. This is sort of the theory of change. I'm not going to go through all of this. I love a good process, but I don't want to spend my time talking about it. But there are some key things here. And so part of that in the first block under strategies is really around inquiry and analysis. And it's about the use of data. It's about the use of data. It's about having common measures. And it's about sharing that data, which in a healthcare system is short of impossible to do for lots of reasons, almost none of which have a great deal of legitimacy to it, frankly. But what's important about the data is in working, if you're a clinic, you have lots and lots and lots of data about the health status of the patients that are seen in that center. You're probably less aware of what other needs, what other assets exist in that community. And so the idea of the inquiry is really that the clinic and the community both have relevant data that should be talked about and used as part of the planning to solve a common community health problem. It can't be solved just by community-based organizations. It can't be solved by individual citizens, and it certainly can't be solved by clinics looking in a very siloed fashion about information about what's going on in their community. And so this initiative is really about supporting how organizations can create this, develop relationships of trust where that they can take that data and begin to work with it and understand it and appreciate it, not judge it, but appreciate it as foundational in understanding what's really going on in those communities. The other block there that's highlighted is really around leadership. And so a question was asked earlier about how to engage in this work and what's important about it. It's first of all about intent. You have to want to do this work. And you have to want to do it in tandem with others that have some shared understanding of the issue that you're trying to address and that are willing to do the long, hard work. It's a journey. It's not a destination. And part of that work, and I would say what's central to the design in any effort, is the extent to which trust is being built. And so I think for us and in the community-centered health home, the idea was that the community began to look at the clinics differently as some place that you go to treat illness and infirmity, that you really began to look at them as a trusted partner and as a problem solver with you around whatever the issues that you're attempting to address. And so a lot of learning, a lot of work around that initiative is really helping clinics understand what real partnership looks like in a community, and vice versa, helping community-based organizations understand the clinic as a trusted partner in solving a problem. The impact of this is really to get to what I think is what is the crux of addressing equity, and that's around policy systems and environmental changes. Again, it's work that has to be built up. I think, again, it has to be taken with intent from the onset. Sort of what you were saying earlier is that I think we talk about health in all policies, but you're quite right. It's now an equity in all policies. And I think that health, being understood as health and wellness, not just health care, can certainly work in tandem and very strategically with communities to create a place that people want to come to, that they really do want to live and work and socialize and raise their kids there. Can I have the next slide? And so this is just an example of some of the work. We funded 12 clinics in different parts of Texas to do this work. Our service territory is 57 counties in East Texas. We're approximately 10% of the state and have some of the poorest health outcomes, not just in the state, but actually in America. So the work that these communities have decided to undertake is very difficult for lots of reasons against the context of a state that politically does much to create those structural barriers that prevent specifically poor people from accessing services. So we didn't expand Medicaid. What Medicaid pays for is very little. It's for basically children between 0 and 18 and pregnant women up to 30 days postpartum. So there's a lot that does not exist in the state to support communities working together to do this work and move the trajectory forward. But there are some successes in that. And so I just want to talk about a couple of them. One of the things that we learned in working with clinics and community partnerships, the success of the work of addressing the issue in tandem with the community has only been as successful as the partnership is successful. So if partnerships are developed, if community organizations that do not have the infrastructure support, the financial support, the community will struggle because there's not agency there. And I think it's the role of philanthropy to build the capacity and build the skills of those communities, again, with intention to build that skill set. And this CCHH model has really given us a laboratory in some ways in which to do and understand that work. So that's one of the fundamental learnings that we've taken away. In that regard, to the point that Armando was making in terms of where one of the clinics are at the Aldine community that he talked about, one of the things that you need to know about Houston is that there is no zoning law out there. It's kind of Wild West in that regard.
I will just note, as the planner, it is the only large American city without zoning. So
Yeah.
this is quite unusual.
Yeah. So with that said, and some of the problems that he identified of what life is like in an unincorporated community, I think being able to have health and an actual healthcare provider, I think we understand the social determinants of health, but there is also a health institution as an anchor that's important in that work. And so at the Aldine site that's part of Baker Ripley, one of the clinics that is participating in this initiative called the Hope Clinic has actually established a federally qualified health center in that community. And I think that one of the things that made that possible was the extent to which Baker Ripley of itself had that mindset. And I think because they were and had worked in the community as a trusted partner, then introducing a community health center into the neighborhood that did not necessarily have a relationship in that part of town became really, really important in terms of developing that kind of partnership. And also because of the other kind of services that Baker Ripley provides, it really enables the clinic to work in tandem to address, again, health, not just health care, as part of the implementation and work around that particular area in Houston. Can I show you the next slide, the next one? Well, let's flip back to the other one. This is a garden with people around it. I think we're all familiar with community gardens. But I think that's great. One of the things that we learned is many of the clinics had identified, many of the communities had identified diabetes as something that they wanted to address. And so the thinking kind of goes to, diabetes, and certainly there's a treatment intervention there, but we immediately go to physical activity and food, both of which are very important in addressing diabetes. And many of the clinics sort of launched these community gardens, built environment types of projects. This is an important learning for us, and that's understanding built environment as a social determinant of health. And it's also understanding again, structurally, somebody was asking earlier, what is the sustainability of some of these projects? I think what we've learned at the onset of the project is that there was probably some pre-work that needed to be done before the sort of usual answer around sidewalks and gardens got established. And that is, there are city ordinances, there are planning departments that have money and resources that by law should be and are intended to be invested in communities. But if communities aren't aware of that, then that's not where they're going to start thinking about it. And I think it's for, philanthropy, I think it's for the institutions that are involved in this work to help them understand that and build that skill and competency first. We could have jettisoned the work of some of these gardens and some of the built environment projects had we understood better, had we been able to include the community and the organizations to have understood that, so that there's lift already, that we're holding accountable those institutions, those governmental entities that are supposed to be doing this work with them in the first place. And so I think that is an important thing that has to be considered before we start getting into the sidewalks and the gardens. Not knocking that, but I'm just saying if you want that work to be sustainable, it has to be looked at as a systems approach. And I think it is incumbent upon all of us is to understand what money is already there so that it can be leveraged as opposed to being recreated or duplicated in some way. The next slide. Okay, this is obviously people exercising, but this is probably my best example of the work within this initiative. This is actually in a community. It's in a small, well, nothing small in Texas, but it's in a particular area that has a lot of, the community self-identifies and is very clear in terms of what their community is. I mean, both by geographic boundaries as well as culturally, residents who are in the community, et cetera. And so it was also a community, there are high numbers of immigrant families, there are even higher numbers of undocumented families, and in the context of our political framing now, there's a lot of fear in this community. And so even though services may be available and accessible, people aren't coming out to them. And so in this particular neighborhood, the work was done with Memorial Hermann Hospital. It's also working with Avenue Community Development Corporation. There is also health services and other providers. The food bank is involved with them, et cetera. And so what they wanted to do, back to the diabetes example, was to create a built environment project around sidewalks so that there would be some sort of walkability in the neighborhood. The difficulty being is that people are not coming outside of their houses. And so there was a park called Clark Park in that area that really had fallen on bad times. There were criminal activities that were identified. There was a lot of loitering. It wasn't a very pretty place. It certainly didn't look like any of the pictures we saw this morning. In fact, quite the opposite. And so what Memorial Hermann, through its resources, was able to do, and also working with the partners that they already had established as part of their referral network, was to begin to have conversations with the community in terms of what would be appealing to you, and helping us do this work that would help this community. And so one of the things that they prioritized was the sort of reimagining and development of the park. And the interesting thing about the park is that there was a great deal of fear of the people who were living across the street because it was not a welcoming place. There were lots of gangs, criminal activity, et cetera. And so what the project was able to do, what Memorial Hermann decided to do in tandem with the community, was actually reclaim pieces of that park and begin to rebuild it. And so what people literally across the street peering out of their windows were able to see that somebody else who cared was beginning to take care of this park. And they could see garbage going out of the community. They could see sidewalks being poured. They could see grass being mowed. And little by little, started to come out of their house as a matter of just curiosity to a great degree. There were also some community health workers that were also dealing with people and making them aware of what was going on. And so, long story short, what that project was able to achieve is that through the relationships that they had with the school in the area, the healthcare center in the area, their other partners, was to really, again, to this point about creating trust and having conversations, such that what had been occurring is that there were some teenagers who had been loitering in the park. Somebody across the street would call the police. The police calls up. They bring, they arrest the kids. It starts off in an entirely different trajectory. What they have now been able to do is actually, when this occurs, have the police department actually work with the school that's engaged, get in touch with the parents, get in touch with the community health workers, and really work with the family as opposed to what was their usual play of arresting that child and really setting them up for a bad situation for the rest of their life. I think that's one example of what's possible. One, when there's trust, one, when change is done with intent, and that there's also an eye toward using the assets of a community to actually build a community, and understanding how a healthcare provider that's generally looked at as someplace I go when I feel bad to someplace that, while I still go because I feel bad, I also understand that they have other resources that are there to help me in support of my community, in support of the families, and in supporting what really is a sustainable, healthy place over time.